Great. Great. Good morning. Hi, my name is Andrew Jones. I'm with LKC Technologies. We're here on the floor of the exhibit hall for the American Academy of Optometry in Boston. I'm here with Dr. Stephen Ferrucci. You'll probably remember electroretinography from your time in optometry school. Usually it was a very large device, took a lot of time, it was difficult on the patient, it was difficult on the practitioner as well. Well, we're here to talk a little bit about a new device, the Retival, that is designed specifically for the clinic, and it miniaturizes ERG and brings that great technology to your office. So I'll get started with Dr. Ferrucci here. So Dr. Ferrucci, tell us a little bit about your practice, where you're from, that kind of thing.
Yeah, sure. So I'm at one of the VAs in Los Angeles called the Sepulveda VA. It's in Los Angeles. Pretty busy practice, older patients mainly, a lot of diabetes, a lot of AMD, a lot of retinal disease, glaucoma.
Yeah.
So very medically based practice.
Okay, so you're seeing a lot of diabetic
Yes,
patients in your
yes.
practice?
Sure.
And what are some of the challenges that you face in managing your diabetic patients?
Yeah, it's a great question. One of the main issues with the patients with diabetes is, getting them into the clinic and making sure they have any retinopathy, and if they have retinopathy, trying to find it as soon as possible. And once they start to lose vision from the retinopathy, it's sort of almost too late. The goal really is to, if they have meaningful retinopathy, to get it treated before it starts to affect their vision. So we can use things like the OCT and a retinal camera and what have you to look at the structure of the eye, which is great. But with the Retival, you can also look at the function of the eye as well.
Mm-hmm.
So it's more of a functional test versus a structural test, which is nice. And the other thing, I kind of liken it in a way to a visual field in our glaucoma patients, in that we often see defects in the visual field before we start to see damage to their optic nerve.
Mm-hmm.
It's the same thing here. You can start to see, or tell that they have damage, I should say, to the retina using the Retival before you actually start to see the damage. So it's a way to know earlier if they have any problems with their diabetes.
Excellent, excellent. Now, when you use the Retival with your diabetic patients, what kind of test protocols do you use?
Yeah, so there's a bunch of different kind of test protocols on this, but for the diabetic patients, I use a thing called the DR assessment, diabetic retinopathy assessment, and essentially it uses 4 different parameters: the pupil size, the wave, the size of the wave, the amplitude of the wave, the time of the wave, and the patient's age. And it uses those 4 things, and it comes up with a number. And they've done studies, and they found the number 23.4 is important. And if a patient has the number 23.4 or higher, they're 11 times more likely to need ocular intervention, surgery, laser, something like that within the next 3 years.
Wow.
So when I do it, I'm looking for that number. And if I see that number, and it makes it very easy. If it's that number higher, it shows up in red. So even someone as sometimes slow as me can do this, right? So it'll show up in red, and then you have a problem.
Okay. And how does that change? So let's say someone does show up in red. How does that change the way in which you manage that patient?
Yeah. So I kind of use a couple different ways. One, if I'm seeing a patient, they have minimal to no retinopathy, and then I do the test and their value is low, 17, 18, something. I know that's a patient that we're in pretty good shape, and then I'll have that patient come back, 6 months or 12 months, whatever I feel is appropriate based on the level of retinopathy. Versus if I see a patient, maybe the retinopathy doesn't look that bad, but I do the Retival and it shows me a bad number, then I'm probably going to refer that patient sooner than I would have just by strictly looking at their retina.
Mm-hmm. Oh, okay. And so with the Retival, where do you use it? How do you fit that into your patient flow?
Yeah, well, it's really easy. I mean, the nice thing about it is, like you said before, it used to be this huge machine, right? And I don't know if I've ever seen one. Maybe once in school, but they're huge, And now you can bring this to the patient. So rather than having a patient go to a visual field, a dedicated room, I can just have my tech, hey, go please run the Retival on the second room on Mr. Jones,
mm-hmm.
or what have you. So the tech can just bring it right to the patient. So you can just do it in the exam lane or wherever wherever works for your practice.
Excellent. And how do your techs find using the device?
Yeah, it's really very easy. It's very, very easy. I mean, I think, when they train in 5 minutes, someone comes in, boom, boom. I think probably the hardest thing, and it's even not that hard, but is putting on the sensors.
Mm-hmm.
Because you have to put on the sensors and you have to line them just right in order to get good readings. I think that's probably the hardest thing. Once they get the hang of putting those on, the rest of it's really quite simple.
Excellent, excellent. Well, thank you very much, Dr. Ferrucci.
Sure.
Were there any questions from online? All right. Dr. Liffert, did you have any questions as well, or?
Yeah, so when you're doing these DR scores,
mm-hmm.
obviously it's undilated. as far as integrating the Retinol into that, you have them do it first, and then you dilate the eyes.
Yeah, right. Because one of the parameters it uses is pupil size, so you want to do it before they get dilated. Yeah, so I'll usually do it before they get dilated, then we'll dilate them, and then we'll proceed with the rest of the exam.
And it's only reimbursable if they have diabetic retinopathy.
Yeah, I believe that's true.
So it wouldn't be. So let's say I see a patient for the first time, they have diabetic retinopathy. I'd plan for this DR score the next follow-up visit.
Yeah, you can certainly do that.
Undilated, and then dilate their eyes for monitoring.
Right, you could certainly do that. Yeah, you could certainly do that, or when they come back for their follow-up, or whenever you're going to see them next time. Yeah. But it is better. You want to do it undilated because of the pupil, size comes into play. Yeah.
Great.
Thank you.
Thank you very much, Dr. Lifford. And any questions from online? Well, thank you very much, Dr.
Sure.
Ferrucci. Appreciate you stopping
Sure.
by today.
Sure.
Thank everybody online for joining us. Please join us later today. We have Dr. Schweitzer and Dr. Simbor also coming by our booth to give some talks. So thank you very much for joining us, and have a great day.